Assalamu alaikum and good evening to you all. Welcome to yet another medical educational program by SCP Bangladesh chapter. It is a program specially designed for the final year MBBS students of Bangladesh. We call it the Master Class on OSPI, organized by SCP Bangladesh chapter and supported by Bangladesh Society of Medicine. By the name of the title, you guessed it right. It's going to be a program which is designed for the medicine OSPI of final professional MBBS examination. Today's topic is going to be X-ray. As you all know, it is a vast topic, so one episode won't be enough. So there will be another part of this topic on the next episode. Talking about X-ray, who would be more efficient than the legend himself, Professor Khan Abul Kalam Azad. Yes, our today's class will be conducted by Professor Khan Abul Kalam Azad sir. He is the governor-elect of SCP Bangladesh chapter and former president of Bangladesh Society of Medicine. Today's program will be chaired by one of the best physicians of our country, our very own governor of SCP Bangladesh chapter, Professor H.A.M. Najmul Ahsan sir. Sir is also a former president of Bangladesh Society of Medicine. As a chief guest, we have another living legend, Professor Billal Alam sir. He is the head and professor of medicine, Dhaka Medical College. He is the current president of Bangladesh Society of Medicine. As the moderator with us, we have one of the inspiration for the young doctors of this time, Dr. Muhammad Rafiqul Islam sir. He is the Associate Professor of Medicine, Sohrawardi Medical College, and he is also the Secretary to the Governor, SCP Bangladesh Chapter. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Muhammad Rafiqul Islam sir. Dr. Muhammad Rafiqul Islam sir.
Thank you, Dr. Prince, for your wonderful introduction. And after such a nice introduction, we have nothing to say. Honorable Governor Sir, Professor H.M. Najmul Ahsan, Honorable President-elect, Governor-elect, Professor Khan Abul Kalam Azad Sir, and Chief Guest, Professor Muhammad Billal Alam Sir, and my dear loving students, Assalamu alaikum. Today we are on the class of master class on OSPI for MBBS final year students, and without delay I will request our speaker Professor Khan Abul Kalam Azad sir to start the session, which is X-ray, predominantly chest X-ray. Thank you.
Thank you. First of all, Assalamu alaikum. Good evening, Dr. Prince. Thank you very much. You make the beginning always very smooth and soothing, and your introduction is wonderful all the time. To pay respect to the teachers is definitely one of the important aspects what American College of Physicians and Bangladesh Society of Medicine, both the organizations are practicing. And I'd like to give thanks to Professor Rafiq, who is really not only an inspiration, what was mentioned by Dr. Prince, but also a really a person who loves learning something, who loves to disseminate the knowledge among others. And he remains busy with all these type of activities, the academic sessions. I'd like to congratulate Professor Rafiq for these brilliant activities. Honorable chairperson of the session, Professor H.M. Najmul Ahsan sir, my very valued, respected teacher, and the present governor of Professor H.M. Najmul Ahsan, whose whose guidance and love for this type of your academic sessions really made him a very distinguished person, and also very lovable person by the students and the teachers. Also, I came to know that today's Chief guest is Professor Mohammad Bilal Alam. He is the present patient, Bangladesh Society of Medicine. I like to give him thanks for his presence. And also, I came to know that Professor Kazi Tariqul Islam sir, who is not only brilliant in his academic activities, his organizational activities, his presence in a meeting means something different. And really, his love for the students is an inspiration, is a pathfinder for the future generation teachers. I'd like to congratulate Professor Kazi Tariqul Islam sir for his excellent presence. And also, I'd like to congratulate the participants who are attending this session on X-rays. So without any more discussion, I want to go to the topic, sir. By seeking the permission from our chairperson, Professor H.M. Nazmul Hasan, sir, I will be continuing it, and I will try to focus on very important aspects. What a doctor, when he will be practicing this medicine, what he will be looking at the X-rays. And also, before becoming a doctor, he will have to appear in the exam. In the OSPE, he will have to go for some X-rays. And also in the oral part, there are X-rays. So X-rays are the important components where you have to show that you have got the knowledge to read the X-rays and to identify the abnormalities in an X-ray. So I want to go to the second slide, please. Can you listen to me? Yeah. The first X-ray slide. Yeah. So you know that for the students in 5th year, they'll have to appear after written examination. The very important part of the practical side is OSPE. At this moment, we have got 5 stations of OSPE, 10 stations of OSPE, 5 marks in each station, and we have got 1 X-ray station in medicine, and also another X-ray likely to be present in pediatric section, which will be comprising of your 2 stations in pediatrics. So that is very important that you have to look at the X-rays and have to identify the problems, and then you can answer the questions. So within 5 minutes, you have to look at the X-ray very carefully, and you have to identify the problem, and then you have to answer the questions. So that is the important components in the OSPE. Next slide, please. So if you go to the X-rays, you know that many investigation tools began to influx for diagnosis of different situations in clinical conditions, in medicine, surgery, gynae, and this was discovered by Röntgen and the German physicist. It was discovered in 1895. So these are also known as the Röntgen X-rays, the Röntgen rays, and in Bengali we say that Röntgen Roshi. So that is very important to say that a person, a physicist, he was the first man who could identify that X-rays can be an important component in diagnosing internal organs, the bones, the viscera, in many other areas which can be identified properly, and many of the disease states can be delineated by X-rays alone. And after discovery in 1895, from in 20th century and in 21st century, we found that X-rays were very important diagnostic tool. Along with the X-rays, by using the same type of your electromagnetic radiation, we found that we had CT scan, we had your MRI. So these are the development on X-rays. But the beginning was the X-rays. When I began my career as a doctor, at the time we had to gather important knowledge on chest X-rays, what I will be covering today. My component will be focused on the chest X-rays, and that is very vital for the doctors, the most important area, where still after we found that after discovery of your CT scan, MRI, still the chest X-rays are important components to identify primarily or a permanent lesion which is present in the chest. Next slide, please. So usually for the chest, we go for posterior anterior view. From the posterior side, the ray is thrown into the body and the film is taken. And other views also can be used to see the structures like bones and others by anterior posterior view. And to focus the specific area, we can go for lateral view, the apical view, and sometimes the lateral decubitus view when we have got a confusion about a lesion present on the lower side, whether it is fluid or it is non-fluid. So those are the areas which can be discussed later if we get time. Next slide, please. So in the chest X-ray, you see that once upon a time, when the manual writing was there to be used on the chest X-ray, the patient name, age, gender, and the date of X-ray. Those are very important and vital because, without the correct identification of the patient, if we go for the reporting, so that will bring some calamities, the catastrophe. So these are the important components which are to be ensured that the patient's name is written properly, and the age is very important because age is an important component by which we can find that same type of your radiological finding may differ in the diagnosis in different ages. And also some of the areas which are common in male, some of the areas are common in female, what can be found in the X-rays. So date of X-ray is very important because first identification and then the serial X-rays which can be done to see the follow-up of the X-ray findings in the later days. So that is very important. And also some of the things are very important for a very proper X-ray, because if we see that these things are all right, then a good X-ray is taken. If these are not correct, so the radiological findings will be distorted and we cannot read the X-ray properly. So the patient's position and whether the patient is rotated properly or whether the patient is having a static posture, and also the patient is having adequate inspiration. It is very much related because the lungs are the main organs which are occupying the chest. And the hemithorax, the two hemithorax and the two lungs are there. So the findings will differ during inspiration and expiration. So with inspiration, the air is trapped and a X-ray is taken, and then we can find the important markings what can distinguish the important lesions. So that is important. But if we take more air, that can produce your blackening, so the important findings will be missing. So if important part will be that the breathing pattern is quite important before taking a chest X-ray. And also the different types of powerful radiological beams are thrown into the chest. So if it is penetrating properly, then only you can find a good view of the inner structures. If the penetration is improper or it is obstructed by some things like your heavy body clothings or something else, then the X-rays cannot penetrate and we cannot get a very good X-ray. So that is an important. So for a student, the chest is a case, thoracic case, and we can see that there are mediastinal structures in the midline, the anterior mediastinum, middle mediastinum, the posterior mediastinum. And among them, in relation to the heart and the lung, the structures which have to be looked for properly, and also some structures which can be involved by diseases of the lungs and the heart. Those are very important to remember. So here some of the structures which are named. The first of all, the trachea. You have to identify the position of the trachea, whether it is central, it is more deviated to the right, more deviated to the left. What is the the pattern of your trachea? So that is a very important component that will give you a guideline that what is happening inside the lung. So tracheal pulling, pushing are important in diagnosing, and also so many other things are there. If I see the X-rays, then I will come to make some comments about those structures. And the central part, more on the left side, is the heart, and just you see, heart is a structure of middle mediastinum, but I said the anterior, middle, and posterior mediastinum. An important structure in the posterior mediastinum is the esophagus, and so you have to look very carefully whether anything seen in the posterior mediastinum also. And also heart, the structure, globular structure of the heart, the size of the heart, the shape of the heart, the covering pericardium, and also the angles which is produced by the heart along with the margins of the lung. Those are also very important. Two angles are very important. One is your paracardiac, the cardiophrenic angle. That is very important. And the inferior surface of the heart, that is to be looked very carefully. And then the main structures in the thorax is the lung, and on one side, on both the sides, one lung in each. So you have to identify many diseases in the lungs. And the lungs are covered by pleura. Usually when the pleural space is not involved, you can see that it's the same structure as blended in the lungs, the visceral pleura, and over the thoracic case, inner side, the parietal pleura. So if it is unremarkable, nothing can be said about the pleura. But pleural pathology begins with the costophrenic angle. So whenever you look at the lungs, then you just give a quick look at the costophrenic angles. That is on the more lateral side, on the chest hemi areas. So here you can find whether anything is there in the pleural spaces. And another important component is that the bones can be involved per se, that is the diseases can occur due to bony involvement, or due to lung involvement there can be bony changes. So along with the same time, you can see the bones which are on the chest, the vertebrae, the ribs, the sternum. All these structures have to be looked very carefully whether any abnormality are there. And we know that the diaphragm is a structure which separates the thorax from the abdomen. So on the right side and the left side, and that the liver is there on the right side, it pushes the diaphragm more, and so the right lung is smaller. So you have to look at the smaller right lung and the larger, long, slender left lung. So the left-sided diaphragm is a little bit lower. And also another important thing I want to remind you, that on many occasions in OSPE, the chest X-ray given, but the findings may be there just below the diaphragm, subdiaphragmatic lesion. There may be, that there's something like that. There may be fluid collection. There may be gas collection that is in perforation. You can see those things. And also you have to look at the space below the diaphragm, because on the left side, you can see the gas shadow of the stomach and the colon. By that, you can demarcate that the patient is on the right position, and it is marked rightly that the right and left. Or on occasion, you can find that the patient can have situs inversus. The dextrocardia may be there, the heart may be on the right side, and the liver can be on the left side. So below the diaphragm, we have to look for that. And also many structures below the diaphragm, like pancreatic stones. On occasion, you can look at the pancreatic level, and you can find the pancreatic stone below the diaphragm. On many occasions, when the chest X-rays are given, students look very carefully at the lungs, the heart, but they miss these pancreatic stones. So you have to look at the pancreatic stones, and perforation of the hollow viscus, identifying the sites to identify the situs inversus, and so on. And also on occasion you can find that soft tissues surrounding the chest case may be involved. You can find that there may be involvement of the muscles, there can be involvement of the breast. So these are very important. You have to look at the muscles. And you know, the subcutaneous emphysema, you can find the soft tissue swelling, a soft tissue lipoma, soft tissue neurofibroma, a tumor occupying the chest on the lateral side. So those can be there, which have to be looked. And also on occasion, the breast shadows are important components to identify the lesion. So those are the structures. Before scrutinizing the chest X-ray, you have to look at every details of all these structures. By regular practice, you can reduce the time. You can see this within 10 seconds. If you look very carefully from one another, you just come from the lateral side, and then you see the soft tissue, the chest case, then a costophrenic angle, the diaphragm, the lungs, and then you come to the mediastinum, the heart, and all this structure. So within 10 seconds, if you practice regularly, you can see all the structures, and then you can gradually identify the disorders which can be present in any of the structures, either singly or in combination. Next slide, please. So here you can find that structures which are there. The bony case, you can see starting from the thoracic inlet, the central trachea, the ribs, the division of the trachea forming the major bronchi, the hilum, where the main vessels and structures enter the lungs, and the pulmonary artery, the bronchial artery, the pulmonary vein exit. And then you can see also the major grade vessels, especially the aortic knuckle, over there on the left side. And also you can see the diaphragm, and you can see the costocardiac angle and the costophrenic angles. And you can see in the females, very importantly, that is also one of the identifying areas by which we can say that is a male X-ray or a female X-ray. Or in males, sometimes you can find gynecomastia may be a problem. Then you can identify that by seeing the shadow. So breast shadow is also an important areas which have to look at. And also posteriorly, if you look very carefully behind the heart, you can see the vertebral column. Over the clavicle, you can see the thoracic, below the thoracic vertebra, and also you can find the lumbar vertebrae, and above that, above the thoracic inlet, you can see some of the cervical vertebrae, especially 7th, 6th, and 5th vertebrae. On many occasions, we can see some of the cases where we can see the thoracic, cervical rib is coming into the thoracic area. That can also be diagnosed very carefully. Thank you very much. Next slide, please. So here we have to separate radiologically the lung fields into 3 areas, right? So the upper, mid, and lower jaw. So how it is divided? So if we come at the anterior end of the second vertebra, second rib, that is your at the junction of the costal cartilage. From there, if we draw a horizontal line, so above that horizontal line will be the upper jaw, and from there the second rib, if we go to the third and fourth, and at the anterior end of the fourth rib, if we draw another horizontal line, so below the first line up to the second line, that will be the middle zone, and below that middle zone is the lower zone. So because we know that anteriorly in the midclavicular line, the anterior end of the 6th rib is there, so we can say like that 2, 4, 6 formula like this one. Next slide, please. So here we can see some of the findings in a chest X-ray. We can see the position of the clavicle. It has become so straight, and in the chest X-ray we can find that on the right hand side and the left hand side, if we compare we can find that these are not similar. On the right hand side, we can find that the upper areas, it shows that it is opaque in color, and so the air is not entering into that area. We don't see any air bronchogram, but below that we can see the lung shadow. On the left side also we can see the lung shadow, that is, it is aerated properly, the whole left lung, but the right lung is not aerated properly. At the same time, we can see that the costophrenic angle and the cardiophrenic angle look very clear. Next slide, please. So here, if we want to describe this one, so how we will describe? So this opacity, when we try to describe whether it is homogeneous, that is the lesion is a continuous one, or whether it is inhomogeneous or patchy. So we use the terms the inhomogeneous, patchy, to indicate if we see that some areas of the inflated lungs are being seen with air bronchogram and some areas show some sort of changes, this opacity. So two colors are very prominent here. So if there is air, it will be black. If it is not air, due to some other lesion, it may be a solid lesion, it may be a liquid lesion. It will produce your white opacity. So here is an homogeneous opacity involving upper and the middle zone, because you can see if you count the anterior end of the ribs, that first and second rib, the upper zone, and second and third, a little bit above the third, you can see that there is your the lesion is extending beyond that. So upper and middle zone of the right lung. So a homogeneous opacity in the upper and mid zones of the right lung. So that is the main findings are the which will say that it is the right upper lobe consolidation. This is the consolidation. Now a question can be there, what is consolidation? So synonymously we use the term consolidation with pneumonia. Consolidation means when the lung itself is an elastic structure. So when due to entry of your water or something like that in the alveoli, it becomes solidified. So when it is solidified, we call it consolidated. So the consolidation here, and this is the right upper and mid zone pneumonia. Next point. Here you can see the very importantly, if you see the left side, you can see the extension is so enormous. It is occupying the left upper, mid, and lower zones. You can see a little blackening at the left lower end of the lung area, at the costophrenic. Otherwise, the whole areas are white, opaque. And also, we can see that the patient has got the tracheal position a little bit seems to be in the upper part is central, and so it is not that much deviated. It is pushed a little bit seemingly, but you cannot delineate the left heart border. And you can see the left lung area has been shrinked. It has gone upwards, and you see the colonic shadow, it has pushed upwards. So you can see if you just measure the diaphragmatic margin, you can see the right-sided lung is more inflated than the left one, and the left lung has become smaller. So something is there that the area of the left hemithorax had been decreased, and a lateral view is showing over there. You can see the in the posterior part, you can see this is the lung area where there is inflation with the air. In the anterior area, which is not that black, it is white, the opaque. So the line of the oblique fissure can be seen here. That means the upper lobe is completely involved. So when you find an X-ray like this one, then to identify the radiological involvement and the lobar involvement. On the right side, we know that there are 3 lobes: the upper lobe, middle lobe, and lower lobe. But on the left side, there are 2 lobes. The oblique fissure is dividing into upper and lower. And here you can see the upper lobe and lower lobe, the oblique fissure is coming down. Next slide, next point, please. So here, and radiologically, you can see the homogeneous opacity involving upper, mid, and lower part of the left lung. And you cannot see the left heart border, and the trachea is central in position. Next slide, please. So you can see this is the left, because I showed you the oblique fissure dividing the upper and lower lobe. So by that, you can say that it is left upper lobe consolidation. Though in X-ray, in the posterior anterior view, we can say that, oh, the whole left lung is opacified. So whether both the lobes are involved or not, but by doing a lateral view, we can say that you can see clearly by lateral view that the upper lobe is only involved. Next slide, please. Another X-ray here you can find. If you look very carefully, you go through screening, you can see the opacity occupying the, you see, if you count the anterior end, the lower region is involved here. The lower region shows opacity. Next slide, please. So in the right lower lung field is only involved, and it is your making your indistinct right heart border, right? So this is, you know, in case of your in the middle lobe, horizontal fissure is dividing the upper and middle lobe, and so you can see it is the right middle lobe disease, and here we can find a feature like this one. Next slide, please. So right middle lobe consolidation. So when a shadow over here in the lower lobe is there present, and just making the lateral border of the heart indistinct, we call it Silhouette sign. Silhouette sign. Next slide, please. So important areas to be remembered in case of consolidation. Consolidation, as I said, that it is a pneumonia, the synonym for pneumonia. For the students, it's a very, very common, you know, X-ray, which is very common in the examination, and the teachers like to ask about consolidation. So the consolidation, what consolidation is, what is the radiological definition of consolidation, what happens in the pathogenesis, what are the causative agents which produce the consolidation, and what are the physical findings. That is very important. Consolidation makes the lung field white, that is opaque, and also this opaque field can be produced by your fluid in the pleural space, that is pleural effusion. So it's a very common question in the examination, how to differentiate clinically consolidation from that sided pleural effusion. So if you find consolidation, the important points to be noted for the student, the history, whether he has got fever, he has got cough, and the respiratory distress. He might have chest pain. Sometimes he may have your hemoptysis. So they may have more constitutional symptoms, but these three are important: that fever, cough, and respiratory distress. And you can find, if you look very carefully, you can see for the respiratory system examination, inspection, palpation, percussion, auscultation. You have to count the respiratory rate, and also you see the type of movement of the chest, because the chest movement in a healthy person, it is symmetrical, and bilateral movement, equal movement is there. But in case of your consolidation, which is present on the hemithorax, that will produce restricted chest movement on that side. So you can find asymmetry in the movement. So if a patient has got right-sided consolidation, the left side moves up and the right side remains low. So that is very important. And you can find on palpation, very importantly, you have to see the position of the trachea. You have to check for the movement of the chest, and also you can go for your measuring your chest expansion, and very importantly you can go for vocal frequencies. The patient will make sounds like 11, 99 or tin tin in Bengali. So you just feel over different areas. It is bilaterally you have to palpate, and it is symmetrical. The same areas have to be palpated, and anteriorly we palpate for the vocal perimeters on the mid-clavicular line. The patient will be uttering your tin. Then you see on the right side, left side, right side, left side, left side, right side. So you see the difference. So when the patient makes a sound, the sound wave will come to your chest wall and then it will hit your palm of the hand. So by seeing the intensity of the sound wave touching your palms, you can say that the patient has got this type of your change in the vocal perimeters. And as because it is by the phonation, so the sound waves, it traverses more strongly when there is solid media. So we get the increased vocal perimeters. And as because, you know, the patient will have this type of your solid area. So whenever there is solid area, if we percuss by these two fingers, then we'll find it's a type of dull percussion. So dull percussion occurs in consolidation. Dull percussion occurs in case of pleural effusion also. In case of your consolidation, we call it woody percussion, and in case of your pleural effusion, we call it stony percussion. So like that is when you percuss over the wood, when you percuss over the stone. So the two differences may be there. So that is very important to differentiate for the students. And auscultation, we find three things. That is the type of breath sound and the type of your added sound and the changes in the vocal resonance. So the breath sound is bronchial. Why the sound is bronchial? Because, you know, the air is entering and coming out through the bronchioles, which are patent, but alveoli are affected in consolidation. Alveoli contain the exudation, so they have become solidified. So air cannot enter properly for gas exchange through those diseased alveoli properly, but the air is going from the atmosphere through those patent bronchi. So the bronchial breath sound is being audible, and we don't say that we don't see that the patient has got the normal vesicular breath sound in that particular area. That is very important. The mechanism of bronchial breath sound is that alveoli are affected and covered by exudation, that the bronchioles are patent. So we get the bronchial breath sound. So if you want to say that a single condition to get the bronchial breath sound, it is the consolidation which you have to look for the presence of bronchial breath sound. So if you want to practice for the bronchial breath sound, you can auscultate over the trachea, the division of the bronchi over the manubrium sterni. So over those regions, the sound which is audible, it is the bronchial breath sound. You can practice like that one. And the second one is the added sound, the crepitation, a moist sound. The crepitations are the sounds which can be produced in two ways. One is by the presence of fluid, and if you make enter this air into the fluid, that will produce some air bubbles, and when the air bubbles are ruptured, this rupturing sound is the crepitation. As I say that in the alveoli there are crepitations. So crepitations are with water. So the air is going inside from the atmosphere. So they are producing the bubbles, and at the end of inspiration, the bubbles are rupturing, producing a moist sound. In case of fibrosing alveolitis, without the presence of your fluid, there can be another type of crepitation, which is your dry crepitation. That is not due to your fluid. That is a separate entity. But here we will say that the crepitations are moist sounds because of the entry of air into the alveolar exudate, producing the air bubbles, and by the rupture of the air bubbles, we get the crepitation on auscultation. And as we got the vocal perimeters which was increased, same principle can be applied by hearing through the stethoscope. So when we hear the same thing with the stethoscope, we call it vocal resonance. So same principle can be practiced. So increased vocal resonance will be there. So for the students, I request them that this chart is to be remembered very carefully for their practical examination. Next slide, please. And another question will be there, that what are the investigations you want to go for, because you are seeing the chest X-ray. So chest X-rays are there. The next investigations which can be done, the blood count, if you see the bacterial pneumonia produces your neutrophilic leukocytosis, that is important. But we have to go for excluding tuberculosis in our context. So we go for your common microorganism, your community acquired pneumonia with your Streptococcus pneumoniae, Klebsiella, Pseudomonas, Staphylococcus, and others. But the thing is that you have to exclude this tuberculosis by doing the AFB stain and by doing the gene expert. And occasion there may be a misunderstanding that whether this shadow is due to your community acquired pneumonia or something very different, like a mass lesion or a pulmonary consolidation due to your pulmonary infarction. So a tumor can also produce this type of your similar lesion and also pulmonary infarction. So at the time we can go for CT scan of the chest, which can give us a good idea about the type of underlying lesion. Sometimes a question is given in the exam, what are the complications? There may be pleural effusion. So when there is pneumonia along with effusion, we call it parapneumonic effusion. That is, along with the pneumonia, the effusion is evolved. That is parallel to pneumonia. We call it parapneumonic effusion. So you are seeing that in the lung, there is your consolidation. In the pleural space, there is effusion. So parapneumonic effusion can be there. So if there is parapneumonic effusion, the findings on the chest examination may be different. So if the pneumonia is a prominent one, the effusion is less, the findings of pneumonia are prominent. But if the effusion covers the pneumonia, you will find that the findings of effusion are prominent. So that is very important. At that time, you have to go for CT scan of the chest to identify that the same patient is having your effusion and consolidation. Sometimes this type of your infections, if they persist for a long time, they can produce abscess, and the lung abscess may be a complication, and that your pus can go into the pleural space and can produce empyema thoracis. So as I mentioned that in our context, we have to exclude tuberculosis as a differential diagnosis, and sometimes we have to exclude bronchial carcinoma if the lesion is a subacute one, more than 3 weeks, then you have to go for tuberculosis and bronchial carcinoma. Next slide, please. So simple questions, by getting the answers, now you will get the questions in the examination. So 3 positive findings in the X-ray, now you can answer. What is your radiological diagnosis? You can answer. 2 differential diagnosis, you got the differential diagnosis. And the auscultation and percussion finding, you got the points. And other investigation we mentioned already. And complications which are present, which can be there, we mentioned. And the treatment plan for the patient. So if it's a community acquired pneumonia, so simple antibiotics in combination, so that can be given. And if it is tuberculosis, tubercular lesion, if it's a bronchial carcinoma, then we can go for surgery, or we can go for radiotherapy, we can go for chemotherapy. Next slide, please. So here the next type of your X-rays are put here. On the right hand side, you can see that the patient has got in the lower region, you can see that it is your the shadow is your opaque. The chest is showing opacity. You can clearly see the first rib, the second rib, a little below the second rib, that the portion of the mid zone. But below that, including the mid zone and the lower zone, all are opacified. But the thing is that the border is a little bit curved, concavity upwards. This is the curvilinear border. Curvilinear border. You can clearly see the linear border of the shadow, the upper border of the shadow. But you can, very importantly, in this case, whether it is pneumonia or something different. So look at the costophrenic angle. It is your occluded. You see the cardiophrenic angle. It is obliterated, and you cannot identify the right cardiac border. So whenever you get this X-ray, what is your diagnosis? Next point, slide please. So what I mentioned here, you can see dense homogeneous opacity involving middle and lower jaws of the right lung with a crescentic or curvilinear upper margin obliterating costophrenic and cardiophrenic angle. So it describes everything what I mentioned. Next point. So what is the diagnosis? Very importantly, these are the typical findings in unilateral pleural effusion. That is, in the right-sided pleural effusion, if you get a typical pleural effusion, gives a radiological feature like this one. Next slide, please. Okay, let's see here what is happening here. You can see some findings on the right side, you can see findings on the left side. On the left side, you can see that more clearly, you can see in the lower region, you can see that a curvilinear border. And also the right side, you cannot identify the costophrenic angle. Let's see the description, please. So dense homogeneous opacity involving middle and lower jaws of both lungs with a curvilinear upper margin. So here you see the findings are bilateral, but on the right and left side is lesser than the first X-ray of pleural effusion. Next point, please. So what the diagnosis is? So here you can find bilateral pleural effusion. Usually unilateral pleural effusion and bilateral pleural effusion, that the diagnosis a little bit different, because pleural effusion itself is a clinical or radiological diagnosis, but the causative agent is to be found out. What is the cause of pleural effusion? For unilateral pleural effusion, we simply say that exudative pleural effusion, that is infection, infarction, tuberculosis, included in the infection, and bronchogenic carcinoma. They can produce unilateral exudative pleural effusion. But in case of bilateral, it is your transudative pleural effusion. You know that the difference between exudation and transudation, depending upon the amount of protein present in the fluid. So in transudative, we go for, that is your liver disease, cardiac disease, and you see that in patients having your nutritional deficiency, all other things. Next slide, please. So in case of pleural effusion, the questions which are put in the history, the physical findings, let's see in history, very important, the patient can have fever, cough, respiratory distress. Respiratory distress occurs in patients when the fluid accumulation occurs very rapidly. And when there is your fluid surrounding the lung, so it compresses the lung, and the lung is, the shrink. So lung becomes smaller. So when the lung becomes smaller, so the patient will get less surface area for respiration, and the patient will have respiratory distress. But if you know that the patient has got a long history, for 3 months, the patient is having your gradual accumulation of fluid in the pleural space and giving compression to the lung, there is compensatory, the increase in the respiratory area in the left lung. Suppose it is in the right lung, the lesion. So the patient will have less respiratory distress. So depending on the type of your presentation and the duration, the patient will have respiratory distress, and that is very important to remember. So more acute the condition of pleural effusion, more severe the respiratory distress is. And the patient is similarly, like consolidation, you will have tachypnea, the restricted movement, the chest movement will be less on that side, and because the lung is not expanding and going down, the lung cannot show its expanding character. So because it is covered by the fluid and it has become smaller inside. And in palpation, it is the common rule, when there is fluid accumulated in hemithorax, it will produce a pushing effect. So if there is fluid in the right side, there will be a pushing effect to the left. So deviation of trachea and deviation of the heart, the apex. So we call it mediastinal shifting. So if you palpate the trachea, you will find the trachea is not central. It has come to the left. And you can find that the patient will have a little bit shift of the apex beat. It is not occupying in the normal position, that is medial to the mid-clavicular line. It has gone to the more lateral. And also, like your symmetry of movement in consolidation, there will be asymmetrical movement. Chest expansion will be decreased. But here, as because the sound which is produced during vocal primitus, it is going inside the lung alveoli and traversing to the chest wall, and because the fluid is restriction the movement of the sound wave to the chest wall, here the differentiating this pleural effusion from consolidation, the vocal primitus will be decreased here. But in case of consolidation, we found the vocal primitus was increased. So that is very important. And another difference in the percussion will be that the percussion note will be stony dull, which was woody dull in consolidation. And in auscultation, you will get nothing. Everything will be silent, absent or diminished bass sound. The vocal resonance will be very faint or even be absent depending upon the amount of your pleural effusion. So these are the important areas. But in case of consolidation, we found that there may be bronchial bass sound and the vocal resonance is increased. And there was crepitation, the added sound. But in case of pleural effusion, even if there is your added sound, we cannot listen to it because the area is covered by the fluid in the pleural space. Next slide, please. So here, so the questions, what we put here, positive finding in the X-ray, radiological diagnosis, percussion and auscultation findings, 3 possible causes of this condition, as because we know that parapneumonic, that pneumonia is one of the important conditions for pleural effusion. Number 2, tuberculosis. Number 3, malignant condition. These 3 conditions are to be mentioned very clearly by the student for the cause of your pleural effusion to be mentioned. And what other investigation would you prefer to reach a diagnosis? Here it is very important because by seeing the characteristics of the pleural effusion, by drawing or aspirating the fluid from the pleural space, that is also a very important aspect that students should learn in their 5th year class. They have to practice this aspiration under the guidance of the teachers, that he will have to be able to draw this fluid through the pleural space, and then he will see the physical characteristic, then chemical characteristics, then your microbiological characteristics, and you see so you see that pleural effusion is to be studied very carefully, and so many other things can be studied by studying the pleural effusion. You know about that in tuberculosis, we can go for your fluid study, we can go for your ADA level, we can go for your gene expert of this pleural effusion fluid. So these are very important areas, and sometimes we can go for your thoracic CT scan, and also on occasion we can have to go for pleural biopsy to find out the cause. So these are the things to be known by the students very carefully, and he'll have to prepare like this one. Thank you very much. Next one, please. So here you can see the chest X-ray. What you can see? You can see the right-sided lung and the left-sided lung are more elongated. The heart seems to be a little bit compressed, and you can see that the more air has made it more black, the lung filled areas. And also you can see almost similar sized diaphragmatic height, and also you can see at the hilar region the bronchovascular markings are very prominent. So but look very carefully at the trachea, it is central. So what is the diagnosis? The points, please. So if we call it hyperinflated lung fills on both sides. The diaphragm has gone down on both the sides, making both the lung fills equal. And you can see the intercostal spaces a little bit, more horizontal and more wide. What the intercostal spaces to be there, more, the going down, but it has become more horizontal, and the cardiac shadow is little bit elongated, tubular shadow. So what is the diagnosis in these cases? So this happens when more air is trapped inside the lung alveoli because of your obstructed bronchial lumen in case of your obstructive airway disease in COPD and in bronchial asthma. More commonly in COPD, this type of features in emphysema are common, but if there is long-standing bronchial asthma, they can also produce this type of features. Next slide, please. Next slide, please. So here you can see what is happening on the right hand side, on the left hand side. If we look very carefully, on the right hand side, it seems that the lung is very long, slender, and it has come down. But the diaphragm seems to be normal. And we can see the bronchovascular markings occupying in all the areas, but more prominent in the hilar areas. But what is happening on the left side? On the left side, it is more black, translucent, and we cannot identify the bronchovascular markings on the left side. Rather, we find something, a little bit of a nodular shadow over the left paracardiac border. We can identify a little bit something there, a little bit a rounded shadow. It seems to be attached with the left cardiac border. So what is this one? Let's see the description, please. So it is hyperlucent left lung, and there is no bronchovascular markings, and this nodular shadow is the small shrinked collapsed lung filled. The left lung is so much compressed by the presence of air in the pleural space on the left side that it has compressed, and the left lung has become so small, it has just only produced a small shadow at the left pericardiac border. So this is the collapsed lung margin, which can be seen very carefully. Look at, and you can see the outer margin more on the left side. If you go through, that is starting from the left lower part of the cardiac margin, and and then you go up, and you can see the nodule. Right, the left border. Right. So and then you see that okay, it is pulling effect or pushing effect. You look at the heart, it has gone to the right side more. If you look at the trachea, it has gone to the right side. So the mediastinal shifting is there. So something is occurring in the left side, which has made the left lung field hypertranslucent, and the left lung is collapsed, and that is your mediastinal shifting. What is the diagnosis? Let's see. So that is another type of your disease that is called pneumothorax. That means air in the pleural space. We found fluid in the pleural space, which called pleural effusion. Now air in the pleural space, we call it pneumothorax. So when a patient has got features like this one, you can see some of the things. Why this air has gone from the alveoli to the pleural space. So that may be a question. So it has occurred so rapidly that it has produced so much shrinkage of the left lung, the collapsed left lung, that the patient will have severe breathlessness. We call it tension pneumothorax, the valvular pneumothorax. So that you can see that one-way entry. Air is entering into the pleural space from the lung, and it is not going out. So it has produced this collapsed lung. And if you look very carefully on the right side, the right lung is more inflated, and is a patient having your COPD, having this rupture, and then the patient has got this type of a tension pneumothorax. Next slide, please. So again, here you can see, if you look very carefully, on the right side, we can see the lung is there. We can see the bronchovascular markings are there. But what is happening on the left side? So here we can see the black lung, that is hypertranslucent lung. And in the earlier X-ray, we found that the patient had a little bit, the collapse margin. But here we don't find like that. But here you can see that the lower margin of this black area has produced a horizontal line. So this, your horizontal line is produced that below if there is your fluid and above there is air. So both are there in combination, that in the lower side hydro, in the upper hydropneumothorax. And if you look very carefully with the help of the arrows, the black arrows, you can see the margin on the left paracardiac region, a small shadow. That is the collapsed lung margin. Let's see the description. And also you can see the pushing of the heart on the right side. So hypertranslucent lung field on the left side, devoid of bronchovascular markings, collapsed lung margin, and trachea and mediastinum shifted to the opposite side, and we find the air fluid level. So what is the diagnosis? The hydropneumothorax. Let's see, left-sided hydropneumothorax. So that is very important. Next slide, please. So in pneumothorax inspection again, tachypnea, restricted chest movement. So you can find the deviation of trachea, asymmetric movement, vocal fremitus will be decreased on both the side, in the upper side and the lower side. In both the areas, you can find the decreased vocal fremitus. And over upper regions, in percussion, it will produce your hyperresonance. And in the lower region, you will find that the patient will have the dullness. Right, this is very important. Dullness on the lower region on the left side, and hyperresonance on the upper side. So this is the area which is to be focused for diagnosing your hydropneumothorax. And because on both the areas by auscultation, you can't hear anything. There will be absent breath sound, no added sound, nothing will be there. But by percussing, you can identify that the upper areas hyperresonance, in the downside you will get dullness in the same patient. It is more possible on the left side, but on the right side, because of the presence of liver dullness, on occasion there may be a confusion, but you will find the liver dullness goes downwards, and you can feel the liver inferior margin more lower than the usual, and the liver can be palpable on that occasion. So that is very important. So again, the breath sound and the vocal resonance both are, inaudible or less audible. Next slide, please. So, the spontaneous pneumothorax, very important. If something occurs, a lesion in the subpleural area of the lung, so that is the more area, vulnerable area, it occurs. That is very importantly in case of your COPD and tuberculosis. In COPD, there are areas of the hyperinflated air spaces. We call it your bulla. So subpleural bulla rupture is one of the important causes. And we saw in one of the earlier X-rays that in COPD patient, we found that the patient has got tension pneumothorax. So subpleural bulla or subpleural tubercular focus, if they rupture, they produce more commonly this spontaneous pneumothorax. But on occasion, in patients with bronchial asthma, because it has become more inflated, and there may be on occasion there may be rupture. The abscess, there can be a small abscess rupturing into the pleural space that can produce your air to enter into the pleural space. In case of pulmonary infarct also, malignancy, or sometimes on cystic lung disease. So here, very important in pneumothorax, it is a very emergency, and we have to go for needle aspiration. Wherever you work, you have to go for insertion of needle, and then you have to bring out the air. So for the students, I want to say, needle can be inserted for several regions into the thoracic area. Number one, for bringing out your fluid aspiration, because fluid produces your gravitational changes, it goes down. So you will have to go for the lowermost area for most dull. You have to go for your needle aspiration from that area. Air, when there is air, the pneumothorax, it goes up. So you have to go for second intercostal space. And in case of your consolidation, you have to insert a needle to find out the nature of the lesion. So these are the times when you have to go for insertion of needle to find out the exact cause of underlying changes in the X-rays. And for pneumothorax, to allow that air not to be collected continuously, we can go for intercostal tube drainage. We call it sometimes water seal drainage. Water seal because no air should go inside the drainage tube from the atmosphere, but when that will be collected in the bottle, that will go outside in the atmosphere without allowing air to enter into the bottle. Next slide, please. So here also another chest X-ray. Can you find something? If you look very carefully, the thoracic case and subcutaneous tissue case, the right lung, oh my God. On the right lung, I find a lesion occupying the upper and middle zone, and you see a very circular round area, and the round area with the clear-cut margin, and in the center, in the upper part, we can see the blackening, and in there may be a line, horizontal line, and below that we can see the opacity. So let's see the description. So this type of lesion, what this is a cavitary lesion. A cavitary involving the upper and middle zone of the right lung with an air fluid level within it. So what is the diagnosis? A single lesion having this sort of thing. Air is there, fluid is there. So this is the feature of your lung abscess. Lung abscess can produce different type of your radiological changes. It may be so big, enormous, the whole area may be your opacified with your more pus in the cavity. There may not be any your black areas. But if you get an X-ray finding like this one, it's very easy to answer that this is the lung abscess. Next slide, please. Again, on the left hand side, you can see the similar changes. I don't want to go for discussing. Next slide, please. So here the left-sided lung abscess. Next slide, please. So in lung abscess is also a little bit less common, but it is given in the exam X-rays because a very clean-cut finding is there. You have to identify the rounded lesion. You have to identify this lower white area, the upper black area, and the air fluid level. And you have to identify the side of the lesion and also the area of the lung which is involved in by the abscess. So history, here you can see the lung abscess is a very toxic condition. The patient will have high-grade fever, chills and niger. The patient will have your productive sputum, and that sputum will contain so much, fetid, offensive smell, the foul-smelling sputum. So the patient will have very high temperature, and if the abscess runs for a long time, the patient will have changes outside the lung area. And one of the important findings is your clubbing. So it is a suppurative lung condition, and you know that #1 cause of your clubbing is your suppurative lung condition. So among all the suppurative lung condition, lung abscess is one, the bronchiectasis is #2. So clubbing is there, and if you see that the patient has got a lesion, opaque lesion over there, that is clubbing with it, then you can think of your lung abscess. If the patient has got no productive foul smelling sputum, he has got a shadow like this, rounded shadow and clubbing, then bronchogenic carcinoma will come as the first diagnosis. So if you go for percussion, because you know that fluid will be there, the pus will be collected. Over the pus there may be dull, but theoretically you have to think of because in the cavity there are also some air that can produce your hyperresonance. But on occasion, the fluid surrounds that air, surrounding this cavity, that this air is inside in the middle. So you may not get this your hyperresonant sound because of the presence of the air inside the pus. And the patient will have this, the lung is involved, the alveoli are involved. So, but the bronchial tree is uninvolved. So the bronchial based sound is a feature, and the patient will have your increased vocal resonance because of your solidification of the lung. Next slide, please. So next, investigate full blood count, sputum investigations have to be done. and on occasion CT scan of the chest to be done. And this abscess can rupture and can produce your pus in the pleural cavity, producing empyema thoracis. And on occasion, the patient can have bronchiectasis that can produce dilatation of the terminal bronchiole to produce bronchiectasis. And they can metastasize to different areas. They can go to the blood, and they can go to involve, very importantly, the brain can be involved. There may be cerebral abscess, a very fatal complication of this lung abscess. Next slide, please. So here you can find what I mentioned earlier, a little bit ago. I mentioned about that condition. You can see what happened here. You can see something rounded areas, round cystic spaces. These are not like abscesses, what we found in the abscess, but multiple areas of rounded cystic spaces. And we can find some of the patchy areas which show that they are the patchy involvement, not like your normal lung tissue. So these are the areas involved, more on the right side and lesser on the left side. Let's see the description. Next slide, please. So multiple cavitary cystic lesions involving lower zone of both lung fields and upper and middle zone of the right lung field. You can see that more on the right side, less on the left side. Next point, please. So it is the typical feature of a cystic disease, very common in our patients having some sort of disease like this from childhood. The patient can have various type of involvement where the bronchioles are involved. Here the lung alveoli are not involved. The bronchial dilatation you are seeing, we call it bronchiectasis. So ectasis is your dilatation. Bronchi is for the bronchioles. So the terminal bronchioles, when they become dilated, we call it bronchiectasis. So bronchiectasis can be unilateral and can be bilateral. It is very easy to manage when it is unilateral, but very difficult to manage when it is bilateral, because surgery gives a good result in unilateral lesion. Next slide, please. So also a very common condition in our country, a doctor, a student should be oriented by this type of your findings in a chest X-ray. Here you can see the right side, some changes. Here you can see the lung involvement is there. Here you can see the lesions are there which are occupying the upper and mid zones. Here we can see these are not homogeneous. These are the spotty lesions, the patchy, we call it patchy lesion. And here we can see the trachea is central. Here we can see cardiophrenic and costophrenic angles are normal. Here we can see the lung, the heart is not involved. And so let's see the description. Please, next slide. So patchy opacity is involving upper zone of the right lung. Next point, please. What is the diagnosis? This is the typical feature in our country, that is your pulmonary tuberculosis. In our country, in other countries, you can find them produce many types of your differential diagnosis. But for our students with this type of X-ray in the upper region, this type of patchy opacities, definitely, without any mistake, you have to say pulmonary tuberculosis, even if the patient has got negative sputum for AB. Next slide, please. Here you can see the X-rays, what it seems that he has got extensive involvement bilaterally. You can see the upper and mid zones of both the lung fields are involved, but the left lung has got a more lesion and the right lung a little bit less lesion. And here I want to attract on one point, that is, you see the costophrenic angles on both the sides. Those are obliterated bilaterally. Let's see what the description is. Go to the next slide, please. So you can see again the patchy opacities very extensively of both the lung fields, upper, mid, and some areas of the lower zone on the left side. Let's see what is the diagnosis. Bilateral tuberculosis. Tuberculosis is such a disease which can occur in many fashions, many types. So it can produce a small area involvement, it can produce a lobe involvement, it can produce the whole lung involvement, it can produce bilateral involvement. So you have to remain aware of the types and patterns of involvement by tuberculosis. Next slide, please. Here also you can see the chest X-ray. Here you can see we found some patchy opacities earlier, but here you can see the spotted areas, small, patchy, not patchy. Some are coalesced together, but you can see small areas. Very clear X-ray, very good X-ray it is, and you can see that all the areas of all the lung zones are involved. Let's see the description, what it says. So a millet seed, like a very small rounded seed is your millet seed. In UK it is very common. They have compared with the millet seeds present on both the lung fields. So what do you feel? Why this type of millet like your deposition on all the areas of lung fields? This is due to your blood involvement. The blood flown, infected areas in the lung, like millets. This is called miliary extension. So some lesions are there in one area, and then hematogenous spread, and it has involved all the areas. So it is called miliary. And this is your tuberculosis. It's also another type of presentation in case of Mycobacterium tuberculosis, which can be there, and you can see the type of your involvement in the lungs. Next slide, please. Okay, let's see what is there. You can see, if you look very carefully, the lung areas, the R is there on the right hand side. We can see an area of opacity on the right hand side. We can identify the lower margin. It is very clean cut, and you can see that the medial end of this lesion, the consolidation or the opaque shadow, it has produced a little bit margin, the concave margin on the right lateral margin of the trachea. Let's see the description, please. So dense homogeneous opacity involving upper zone of the right lung, and here you can see that the horizontal fissure, that is the clean cut margin, that is the lower margin, it has been elevated, and you can see the tracheal deviation on the left hand side because of the pushing effect by the medial border of that your lesion on the right hand side. Let's see what is the diagnosis. So you can see that the lungs shadow upper lobe has been shrink, and here you can see that because the upper lobe has produced this type of shadow, the horizontal fissure has gone up. It means the middle lobe has gone up, so it is the right upper lobe collapse. Next slide, please. And it is because of your endobronchial tumor on the right hand side, the surrounding area has been collapsed. So you can see the margin on the right side of trachea. Okay, here also another chest X-ray. You can see that you look at the right margin and the left margin of both the hearts, where the findings are more prominent, and also the hilar prominence is there, and also you can see a little bit your rays or woolly types of your extension from the cardiac margin are there. Let's see the description. Look very carefully. Dense triangular homogeneous opacity in the lower zone of the right lung adjacent to the right heart border. So that is the lesion. You can see adjacent to the right heart border. So here it brings the cursor over this area. Can you see the cursor movement? Okay, let's see the diagnosis. So this is the area you saw that in the right upper lobe collapse because of your tumor over there produces type of opacity over there, but in the right side lower lobe collapse produces a margin like this one, a triangular opacity in the pericardiac margin. That is a very important finding. It has become more straight, and you cannot identify the cardiophrenic angle. It has become more obtuse. So that is the feature of your lower lobe collapse. And here on the right hand side. Next slide, please. Here also you can find some changes over the right sided and the left sided. A little bit, upper region you can find, and the lower region you can see that there are some opacities. Let's see the description, please. So the dense triangular homogeneous opacity in the lower zone of the left lung behind the cardiac shadow. Here the precursor over there, and this is one, this is there. So a little bit, the heart has come more on the left side, because you can identify the vertebral column, the right border of the vertebral column. So it has come over more on the left side. It happens when there is your left lower lobe collapse. So this is the finding like this one. Let's see the diagnosis. Next one, please. Next slide. So left lower lobe collapse. So you can identify by this one. But remember, on occasion, the rotation may be your on the left side. That can also give rise to same type of feature. But behind the cardiac shadow, you have to give a very good penetrating look to identify that triangular area. This triangular area on the right side, triangular area on the left side, they produce this triangular lesion because of your either right or left lobe collapse, lower lobe collapse. Next slide, please. So here also you can see, here if you see on the right side, we can see that the complete opaque shadow, and here we can identify the trachea has come to the right side, and it has come so much on the right side. You can see that on the right chest that is your trachea, and the left side you can see the hyperinflated lung. Let's see the description. Go to the slide. Right. So large dense homogeneous opacity involving the right lung. Trachea is grossly deviated on the right. Right dome of the diaphragm is elevated. Ribs are crowded on the right side, and compensatory hyperinflation of the left lung. What is the diagnosis? Let's go to the next slide, please. So the complete right lung collapse. So this type of lesions occur when there is a big lesion on the right primary bronchus. So if the primary bronchus is involved, no air entry is possible through the upper lobe bronchi, the lower middle lobe bronchi, and the lower lobe bronchi. So the complete collapse of the right lung. Next slide, please. Is because of your big primary bronchial carcinoma on the right lung. So here also again you can see the lung shadow over the right side, and here you can see the position of the trachea in the upper region, and also there is a penetrating view of the vertebral column. On the left side, the diaphragm, you see that it has become straight. The costophrenic angle is obliterated. And if you look very carefully on the right side, the opacity is over there. And let's see the description, please. Go to the slide description. So these are the inhomogeneous opacities in the upper zone, and you can see the horizontal fissure is elevated, and the trachea has come more on the right side, and ribs are crowded over the right upper region. What is the diagnosis? Let's see the diagnosis. So here you see sometimes in your clinical and radiological examination, it is very difficult to say about collapse and fibrosis. So in fibrosis, you can see that inhomogeneous opacities occupying over those regions, and also it has produced shrinkage of that particular area of the lung lobe, and it has drawn the trachea on that particular side, and you see the rib crowding. These are the features of your fibrosis. But in collapse, what I mentioned earlier, a little bit different shadows are produced. Next slide, please. Next slide, please. So here also you can see in a chest X-ray, in a person, you can see the heart. Okay, something looks very remarkable on the right side of the chest. Something from the heart seems to be protruding in the lung. And you can see the margin, giving some sort of your irregular, ray-like appearances. So what is the description? Let's see. So in the hilar region, a sort of opacity present, and their margin is speculated, giving a sun ray appearance. So sometimes, we call it your sunbeam or sun ray appearance. So the margins are there, multiple speculations. What are those speculations? What is the diagnosis? This is the typical X-ray of bronchial carcinoma, originating from the bronchi, and it is protruding into the lung, and the margin shows the sun ray-like appearances. Here it's a big lesion, and also you can find the changes in other areas of the lung, and you can see the involvement of the pleura. You can see the changes in the ribs. So all are to be looked for in this patient in bronchial carcinoma. Next slide, please. So here you can see this X-ray, very uncommon nowadays, but it can be found. What can be seen? We found in bronchiectasis multiple cystic areas, the rounded. In case of lung abscess, we found that is your areas, rounded areas with air fluid level. But here we can see many rounded ball-like areas over the lung. So at that time, the description was like that, your cannonball. So let's see the description, please. Multiple cannonball shaped lesion involving both the lung fields. So many big lesions are there in bilateral areas on both the lung, all the zones. What is the diagnosis? Let's see which produces this type of your cannonball. So from somewhere else, this type of lesions have penetrated the lung tissues, and they have settled in the lung, produced this rounded cannonball-like shadows. We call it metastatic bronchial carcinoma. Right? Next one, please. Next slide, please. So here also we can see the X-ray. What is being seen here? We can see the lungs are inflated, but something is seen in the hilar regions. We have seen all the lung X-rays with the hilum. We have seen the bronchial carcinoma originating from the hilum also, giving a particular appearance. But here in the chest X-ray, something bilateral which are occupying in the hilar region. What are those? And on the left side, you can see that there may be a multi-lobed appearance. Let's see the description, please. So, multiple rounded shadows involving both the hilar region, but the lung fields are normal. What is the diagnosis? Let's see the radiological diagnosis. The radiological diagnosis in this type of shadows are bilateral hilar lymphadenopathy. The hilar lymph nodes are so small that in a normal X-ray, in a normal person, you can't identify the lymph nodes. But when they are involved by a disease process, you can see the hilar lymph nodes. They are present like this one. So there may be a question, which are the conditions that can produce hilar lymphadenopathy? You see, sarcoidosis is one of the important areas which are to be discussed. Lymphoma is another condition which can produce this one, and also in fungal condition. But on occasion, in tuberculosis also you can find this type of shadows. But tuberculosis usually doesn't produce this like one. Sarcoidosis is the commonest condition to produce this one, to be seconded by your lymphoma. Next slide, please. Now let's look to another type of your pathological changes which can be seen by the X-ray. If you give a look at the central part with your both the eyes, you can see that we saw the X-rays and where we found the heart shadow, how much it occupies the thoracic case. It is in the middle mediastinum. But here we can find the cardiac shadow is a very big one, and the very big one but less your hilar markings. Let's see the description, please. So you see this the picture shape, the PR shape, the globular, the cardiac shadow, and you can find that the patient has got normal costophrenic and cardiophrenic angles, and the hilar markings are less attenuated, less prominent. Next one, the slide, the diagnosis is this is the feature shape, the pericardial effusion. So enlargement of the cardiac shadow can be produced by enlargement of the cardiac chambers, especially the ventricles, the biventricular enlargement, and also this enlargement of the cardiac shadow can be there by your presence of fluid in the pericardial space, giving rise to a huge globular shadow. In case of pericardial effusion, the lung involvement is zero. You don't find any type of your hilar vascular markings. But in case of your ventricular involvement, especially in case of valvular diseases or your cardiomyopathy, you can find the patient will have more accentuated vascular markings. Those are also common in case of some congenital cardiac lesions. Next slide, please. So this is the X-ray. Very importantly, you can see when you look at the X-ray, the cardiac shadows are very important. You have to identify the right cardiac border and the left cardiac border. And in the left cardiac border, which is mostly produced by the left ventricle, and on the right hand side, you can see the right atrial border is the main component. And as because the right ventricle remains a little bit rotated on the anterior side, it remains your externally. So you can see the right border is produced by the right atrial border, and the left border is produced by the left ventricle. So here, very importantly, the heart seems to be enlarged, and you can see the left-sided prominence is there, and also some changes are there in the left-sided pulmonary conus, which is also full. Let's see the description, please. So the full pulmonary conus. So as because you can see that in the pulmonary area, which should be as this one, what I say, the concave. That it should not be full. And as because I mentioned that the right border is mainly produced by the right atria, but when the left atrial enlargement is there, it is pushed to the right and it has come to the medial side of the right atrium. So giant left atrium can produce a double right heart border. I cannot show you directly, but if you look very carefully, just medial to the right margin, there is also another shadow shadow that that is produced by the giant left atrium. So giving the appearance of your double right border. And here, what seemed to be a little bit, globular heart. So you have to go for measurement of the cardiac size. So, the cardiothoracic ratio is one of the things. So you have to draw a vertical line through the middle of the vertebral column, and to the highest point or the largest or the longest point on the right side, you have to give a horizontal marking. On the left hand side, you have to give a horizontal marking from the mid central line. Then you just add 2 markings. So, and then if this 2 combination is then less than 50% of the thoracic size, if you measure the thoracic size from the right sided medial side of the thoracic case to the left side, then if you see it is less than 50%, so the heart is not enlarged. If it is more than 50%, then it is enlarged. Let's see the diagnosis in such a condition when the pulmonary conus is full and the right double right border, and as because in mitral stenosis the left atrium is enlarged. So here it is your mitral stenosis. And if there is your giant left atrium along with your left atrial enlargement giving rise to your double cardiac border and the cardiac size is enlarged, then along with that, there will be mitral regurgitation. Next slide, please. So here what you can see, here you can see the heart is enlarged. You see it has given rise to a somewhat similar shadow like your globular shadow. So here you can see it is not like totally globular. The left ventricle seems to be more enlarged like this one. You can see the left side, and also I can see the right-sided double shadow. Here it is more prominent, and the pulmonary conus is full. Let's see the description, please. So enlarged cardiac shadow, bulging of conus, double right heart border, widening of carina. So what is that? Let's see the diagnosis. So as I mentioned earlier, so when this type of feature, the mitral involvement should be there with enlargement of the left atrium, but the left ventricle is along with that involved because of your mitral regurgitation. You might have your aortic involvement as well. So we call it safely radiologically multiple valvular heart disease. Next slide, please. So I don't want to go any further because my area of involvement was up to the chest. I don't want to go to the X-rays of the skull or other bones. So Mr. Chairman sir, it was a session I tried to cover as much as possible, but as we know that it's not a part of your a single 2 hours class, it requires hours after hours to practice the X-ray chest to identify the lesions. But what I believe, I tried to show the common X-rays which are very frequently found in our clinical practice. I hope, Mr. Chairman sir, that the students will be a little bit benefited, and at least they have come to know that what the teachers frequently see in the clinical practice in the chest X-rays in the patient, and what type of your lesions are present commonly in our patients in our daily practice, whether it is inside the ward or it is outdoor practice. So with these few words, I will be very glad to answer any question if the participants ask. And then I want to stop here, Mr. Chairman sir, with your kind permission. Thank you everybody for allowing me to talk for so many minutes, sir. Thank you. Assalamu alaikum.
Thank you so much, sir, for your amazing presentation. Now it's time for the question and answer session. These are the questions that you asked during the live session in the comment section. I would like to apologize first because we won't be able to answer each and every questions, but we will try to answer as much as possible as the time is short. To start the session, I would like to request Rafiqul Islam sir to initiate the question and answer session. Rafiqul Islam sir.
Thank you, sir. What a vibrant presentation from our veteran teacher, Professor Khan Abul Kalam Azad sir. During the COVID time, we could not nurture our MBBS students, especially fifth year students. So I am very sure that this class will help our students understanding the chest X-ray, especially OSPI questions related to the chest X-ray. So few questions are there, not too many. How can we differentiate mesothelioma and thickened pleura radiologically? Possibly this question is not for MBBS students. However, I will request our.
Okay, thank you very much. You know that thickened pleura may be a sequelae or complications or complication after pleural involvement by various diseases. It may be by your serous pleural effusion, but more commonly it is produced by your the empyema thoracis. So thickened pleura has got a feature like that one, that the involvement is irregular, and you can find sometimes there may be the costophrenic angle is more involved, along with that may be involved. On occasion you can find in the other areas, but it is very irregular, the thickened pleura, in case of your post empyema complication. But in mesothelioma, there are several types of your radiological finding in mesothelioma. It can produce a rounded opaque-like lesion, that is your very clean-cut margin. Sometimes there may be calcification, and sometimes there may be fern-like appearance of mesothelioma. So mesothelioma can have different types of presentation, and it is very much localized in areas, and which is different from the thickened pleura in post-empyema lesion. So that may be irregular. Various areas are involved, and the lung may be also involved, showing some changes in the lung because of your sequelae. There may be fibrosis because of post-tuberculosis or post-empyema. So those are the features by which you can differentiate mesothelioma. But definitely you have to go for your if you suspect mesothelioma, because it needs a treatment, you have to go for identifying by pleural aspiration and identifying the mesothelial cells over there. So that needs a very accurate diagnosis. If you have got any confusion, thank you.
Thank you, sir. There's another question. How can you differentiate radiologically tuberculosis versus bronchopneumonia from Sandeep Setri?
Okay, thank you very much. Tuberculosis, as I showed here, as I mentioned, the tuberculosis can be unilateral, can be bilateral, can involve any segment. And you know that history is very important to identify that it is tuberculosis or bronchopneumonia. And you know that tuberculosis is a subacute condition. It doesn't produce in acute situations. And you know, it occupies mostly on the upper regions, and it produces patchy opacities. The patient has got low-grade fever, mostly in the evening. He has got weight loss, anorexia, and all those features. Those will be to be considered to make a diagnosis of tuberculosis, mostly upper region. But bronchopneumonia, and you know that is a bilateral involvement, mostly on the lower region, and the setting where bronchopneumonia develops in patients who are having some sort of your pre-morbid condition. He might have your stroke, he might have your unconsciousness. Then you know the many areas, you know, the infected material can go inside the lung and can be settled in the lower region of the lungs, and the bilateral lower region can be involved by the process which we call it bronchopneumonia. So bronchopneumonia, where you can find the bronchial and the alveolar, both can be involved. So the findings are a little bit different. But to differentiate between tuberculosis and bronchopneumonia, the upper region and the lower region, and the duration and the setting, all these are very important in which patient there is your bronchopneumonia. But to differentiate completely, you can go for a sputum examination. By sputum examination, you can find the AFB in tuberculosis, and your common organisms, the community acquired or nosocomial infective organisms can be found in bronchopneumonia. Thank you.
Thank you, sir. So I will take only one more question. There's another question. What will be the auscultatory findings of lung abscess, and how will I diagnose radiologically
mitral stenosis? Okay, lung abscess, you know, is the finding on the lung. It's a finding on the lung, and it's not a finding in the precordium. So the MS to be detected on the precordial examination. Lung abscess to be detected on the basis of finding on the hemithorax. So this is number one. And as I mentioned, the lung abscess produces, you know, a rounded shadow, and there is fluid inside the cavity. So you will be identifying that there are percussion note will be dull, there will be bronchial breath sound over that particular region. So those are the auscultatory findings, mostly your depending on the lung auscultatory findings. But in case of MS, you will find that the patient will have, you know, tapping apex beat, and you will find that the left parasternal heat, then epigastric pulsation, then you can find the rumbling mid-diastolic murmur, then you can find the features of your pulmonary hypertension, the loud P2, the palpable P2, and you can see all these findings MS. So there is no finding which are comparable to the lung abscess finding, like your dullness or the bronchial breath sounds as in lung abscess. So you don't have to consider lung abscess as a differential diagnosis of MS. So one is in the lung, one is in the precordium. So no similarity. You don't have to think like this one. Thank you.
Thank you, sir. Thank you very much, sir. This is the end of question answer session. Now you are the governor-elect of ACB Bangladesh chapter, and this program is arranged by ACB Bangladesh chapter and supported by Bangladesh Society of Medicine. Sir, my question to Professor Khan Abul Kalam Azad, sir, how will you evaluate the session for a program for final year MBBS students? Professor Khan Abul Kalam Azad, sir.
You see, basically, I am a simple teacher. If you want to say what I am a teacher. So, talking about some topic and giving the opportunity to a teacher, it is the best part of an organization. So, this part is being done by Bangladesh Society of Medicine, who has got a very strong heritage that to arranging this your academic session. To remind you, you know that once upon a time there was only one yearly conference, and where the teachers used to come and they used to talk on various topics, and one day a seminar was there. But Bangladesh Society of Medicine, they came out from that idea and they arranged, you know, more than one day sessions involving junior teachers, arranging all throughout the year a perennial, you know, scientific sessions, the conferences. The same heritage when SCP Bangladesh was formed, American College of Physicians. I like to congratulate our first governor, Professor Kazi Tariqul Islam. But the main activity which was flourished under the guidance of Professor H.M. Nazmul Hasan, my real respect to these two governors and also the office bearers of Bangladesh Society of Medicine, because you know, for the postgraduate student, Bangladesh Society of Medicine, they arrange the orientation class for the postgraduate students, you know, how many years back, to remind you. And also for the undergraduate students, these type of things which were not being done by the other organization. But I like to congratulate from my heart that Bangladesh Society of Medicine and American College of Physicians Bangladesh chapter, they are in combination taking this, you know, this type of your initiative to teach our students. I was very happy 1 year back when I found that the students program in Dhaka Medical College, they were there for 2 days, and what type of discussions were there. I could not attend completely for 2 days. I had to go for so many other work, but so far I attended for 3 hours, 4 hours. It was so amazing. The students of 5th year, the type of presentation and their discussion was so excellent. So first of all, I will say this type of activities in combination with Bangladesh Society of Medicine and American College of Physicians will have to continue. That we have to go for that. We have seen in American College of Physicians, and they make the poster sessions for the student, the 3rd year, 4th year student. They come with your hundreds of your posters. So why not in our next year conference in Bangladesh Society of Medicine, we'll arrange for the students this poster session, and we have made the poster sessions a little bit more in large fashion. We have we could involve more doctors, undergraduate and postgraduate doctors in the poster session. But I will be inviting the undergraduate students also, and I will be inviting the American College of Physicians Bangladesh chapter to arrange for all these things along with your Society of Medicine. And what I believe that American College of Physicians Bangladesh chapter is a part of your Bangladesh Society of Medicine. It has emerged from our Society of Medicine. So interchangeably, we work for each other. American College of Physicians, all those are from Bangladesh Society of Medicine. So everything was possible because of our Bangladesh Society of Medicine. So these type of sessions are really invaluable. You cannot purchase by anything in the world. You cannot. I like to give salute to all the teachers because they have given me the opportunity to speak here. In front of them, in front of these grand teachers, I could talk. It was, you know, I was so fortunate. Thank you very much, our Governor Sir to allow me to become the first speaker in this type of session. Really, I was so busy in the last several days and today also. But it was the most amazing time when I talked for the student. Thank you very much, sir. Thank you. Probably I have given the answer, Brother Rafi.
Thank you, sir. Now we have with us the chief guest, most respected teacher of our time, Professor Mohammad Bilal Alam sir. Now may I request Professor Mohammad Bilal Alam sir to say a few words regarding the presentation and the program. Professor Mohammad Bilal Alam sir.
Thank you. Can you hear me?
Yes, sir.
Yes.
First of all, thanks the organizer SCP Bangladesh chapter for arranging such a time-demanding and very good webinar for undergraduate student. I think all undergraduate students who are connected in this webinar will be benefited. Again, I congratulate Professor Khana Abul Kalam Azad, who has given a lecture so elaborately, that he has covered all the aspects of chest X-ray and chest diseases, which will be diagnosed by X-ray, and simultaneously he covered many things on examination, history, and some other aspect of chest diseases, especially tuberculosis, bronchogenic carcinoma, pneumonia, pneumothorax, bilateral proliferation, consolidation, fibrosis, collapse, secondaries, heart shadows, heart diseases, and combined heart and lung diseases. He covered everything. I think it is not only the lecture of undergraduate classes, it covers all the aspect of postgraduate thoracic diseases and chest X-rays. I think it will help not only the undergraduate student but also the postgraduate student also, and mid-level doctors also. Again, I congratulate the men behind this lecture and behind this educational program, Professor H.M. Nazmul Hasan, who is my teacher and mentor, is extremely helpful for the people of Bangladesh, the doctors of Bangladesh, the medical students of Bangladesh. At long last, he thinks for the student, he thinks for the doctors, he thinks for the poor people, and standard of medical education in Bangladesh. Again and lastly, I congratulate the audience and also member of Bangladesh Society of Medicine, the undergraduate student of different medical colleges and institute, and ACB Bangladesh chapter and organizer for their brilliant arrangement and brilliant lectures. Thank you all.
Thank you, sir. Thank you very much for your nice comments. Now, may I request Honorable Governor, SCP Bangladesh Chapter, Professor H.M. Nazmul Hasan, sir, to say few words regarding the program and conclude. Professor H.M. Nazmul Hasan, sir.
Assalamu alaikum. Dr. Rafiq, am I audible?
Yes, sir.
Thank you for asking me to conclude the session and give some comments. At first, I want to congratulate Professor Khan Abul Kalam Azad for his excellent deliberation, his wonderful presentation. He has given a talk for more than 100 minutes. It is not an easy to get a talk from Khan Abul Kalam Azad, who is very busy nowadays. But when we requested from Professor Khan Abul Kalam Azad to start this session as the first speaker, immediately he agreed. This proves his devotion and commitment to this profession, to students and to doctors of our community, our country. Regarding this X-ray, to become a good clinician, to know X-ray and ECG, this is very important. When a clinician knows how to read a X-ray and ECG, it becomes an advantage for him. He can correlate with the clinical symptoms and also clinical findings. So to become a good clinician, one is to get knowledge regarding the ECG and X-ray also. So we always, Bangladesh Society of Medicine and SCP Bangladesh chapter, we work together. SCP Bangladesh chapter is actually an international part of Bangladesh Society of Medicine. SCP Bangladesh chapter, SCP and Society of Medicine, we discharge our responsibility towards our medical profession, to our residents, to our doctors, to our medical students, but we give more priority to our medical students, which is our future of our medical profession. So this time, we are arranging this episode for final year MBBS students who are preparing themselves for the final professional examination, possibly at the end of this month in some universities, and in Dhaka University is going to be possibly starting on 1st April. So during this episode, we know there are 10 stations. Usually there are 8 topics, and we have requested our legendary professors. There will be 7 sessions, and I request all the participants, all the students to participate and invite them to participate in these sessions. I am thankful to Professor Bilal Alam, Bangladesh, who is current President Bangladesh Society of Medicine. He is also very busy. He has also attended this program. He has also said what is the importance of arranging these sessions. And Professor Dr. Rafiqul Islam, he is always inspiring. He's working, he's giving hard labor and giving time to Bangladesh Society of Medicine and SCP chapter Bangladesh. And Dr. Prince is our IT consultant. And I think this lecture by Professor Khan Abul Kalam Azad, it was a very useful and valuable lecture on X-ray, because normal X-ray is reading normal X-ray, knowing anatomy, normal anatomy and radiology is very important. And then you can practice yourself with abnormal radiological findings. So I think the number of X-rays he has shown the very good common X-rays he has shown, which are given commonly in case of examinations. It will be helpful for all the students. With this, come some few sentences. I again congratulate Professor Khan Abul Kalam Azad and Professor Bilal Alam, Dr. Rafiq and Dr. Prince for their cooperation. And finally, I invite all the listeners and students and also doctors for our next programs. Next program will be on 4th March, and it will be second part of the X-ray. And subsequently, there will be on programs on ECG, instruments, clinical programs, and also photographs. Thank you very much. With this, I conclude here. Thank you.
Sadly, we have come to the end of today's program. We have learned so many important things from Sir about X-ray tonight. It will definitely help to get full marks on final professional OSPE examination, especially in the X-ray part. Many thanks to the speaker, the chair, the special guest, and last but not the least, the moderator sir, for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who have asked very important questions and the interesting ones as well. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on the YouTube channel right after the live session finishes. Our next masterclass on OSPI will held on 4th of March, where Professor Shujat Palsar will discuss on X-ray Part 2. See you all in the next episode. Take care and good night.